Hi, I'm Deb Kimmett, and this is the Pandemic Check-In for November 16th, 2020. As per the usual, our shout out goes to the Massage Health Practitioners and COVID-19 Facebook group for calling some of this to my attention. I also belong to various lists that provide overviews of the research that's out there as well. In this news brief, I cover research that's caught my eye, as well as questions that come up from the Pandemic Check-In group. I also, at the bottom of each slide, include an abbreviated source. The full citation is in a companion PDF file that gets posted with this video, along with the massage therapist takeaway. So the first item on our agenda today is all about vaccines. As of this morning, there are 2 vaccines in the news. Everyone is touting how great they are, but let's take a look because I think it's important for us to understand what's going on here. Pfizer is saying that their vaccine effectiveness is greater than 90% effective, and Moderna's is higher. That sounds and is really incredible, but what does this really mean? Pfizer's not that forthcoming about it, but Moderna explains it very clearly. And once you understand all the ins and outs of what's going on here, there are some concerns. First of all, both of these results are mid-study and are very likely to change as the studies go on. But let's take a look at the effectiveness stats first. Both numbers are based only on about 94 or 95 people. What they did was wait until that many in the study got infected. Then what they did was look at how many of them were given the vaccine as opposed to who was given the placebo. As I said, Moderna was very forthcoming in their numbers. They told you that to get their effectiveness stat, only 5 out of the 95 who got infected were on the vaccine, whereas everyone else who got the virus was on the placebo. Pfizer didn't give you those stats. They only told you that it's based on 94 people. So if you do the math, it works out to about 9 were on the vaccine as opposed to 83 on the placebo. So what they're telling you with these stats is that more people on the placebo got sick as opposed to those on the vaccine. So when they're saying that it's such and such percent effective, that's really only comparing it to the placebo. That being on the vaccine is that much more effective than not being on the vaccine. And this is really good news with how vaccines go because it's much higher than what the FDA requires for a vaccine. They're requiring a 50% threshold for a vaccine to be approved. And it's better than most flu vaccines as well, but don't get too excited yet. The news may not be quite so great, and here's why. First, Pfizer's findings have not been peer-reviewed, and the info comes from a company press release with very few details. And that's why everyone is cautiously optimistic, emphasis on the word cautiously. And as you'll notice, I had to go out to other sources to get that information. As I said, Pfizer was pretty stingy on their details. Also, Moderna's findings also have not been peer-reviewed, but they actually put that information in their press release by saying that once they get further along in the study, they'll submit it for peer review. And just as a note, peer review is really important because that means it stands up to scientific scrutiny. The big deal with Moderna's findings is that Moderna was much more transparent and included some key findings that Pfizer's press release didn't. So for example, that of the 95, there were 11 severe cases, with no severe cases being in the vaccine group. That's really promising. We can't really conclude, though, that the vaccine protects against severe COVID, but these results are promising. They include some demographic data, that 15 older adults, 65 and older, and 20 from diverse communities got COVID. What they don't tell us in the data breakdown is who got the vaccine and who didn't. What is interesting, though, is that they included enough data to do a lot of number crunching and determine that a smaller percentage of older people and people of color got sick than the percentages of each recruited for the study. That's also promising data. Pfizer's press release didn't include any demographic data at all, which questions exactly who they're studying. So then when I went back to their study protocol, Pfizer's study protocol, and did some keyword searching, and their study protocol doesn't mention the word race or color, as in people of color or diversity, all words that Moderna used in their press release. I also did word searches for full or partial words that specifically identify various groups of people of color, like Africa, Black, Asia, and found nothing in Pfizer's study protocols or the press release. Again, contrast this with Moderna's press release that includes this information. This is important because vaccines can affect different populations differently. Pfizer does stratify by age, but while Moderna provided some information on age in their preliminary findings, Pfizer didn't. Again, that's important because the older you are, the more at risk you are for COVID-19. Both vaccines are a 2-dose vaccine, and in the case of Pfizer, it's given 21 days apart. The preliminary results of Pfizer's study was based on what happened 7 days or 1 week after the second dose. So if you heard that protection was achieved for 28 days, that's how long after the first dose that they collated these early results. 7 days of protection from the virus just is not that long. So let's contrast this with Moderna's. They also do 2 doses, but they do it 28 days apart, and their data was collected 2 weeks after the second dose. This is a little bit better news because the total time is 6 weeks, a little longer than Pfizer's, but still the protection from the virus, again, is not very long. Both of these phase 3 studies run for about 2 years after that second dose. But both companies are going to ask for early approval. They're going to ask for approval only 2 months after half of those in the study have gotten the second dose. For Pfizer, that means around now, the 3rd week of November. And for Moderna, that will be in the coming weeks. That's a pretty short time frame to collect data. As a result, we just won't know how long immunity from the vaccine will last until much later. And it also raises concerns about the longer-term effects of the vaccine. While it's been shown to be pretty safe so far, what are the longer-term effects? We just don't know. And because these results were released partway through each trial, experts have raised several questions about it. The Washington Post had a good article raising questions about the Pfizer trial, and we can apply many of them to the Moderna trial too. All of these are direct quotes, and then I'll clarify them. For example, how did the vaccine perform in high-risk populations such as elderly people? We don't know this for either trial so far. Were the cases of the disease mostly mild, or did the vaccine also prevent severe disease? For Pfizer, we don't know the answer. For Moderna, all of the severe cases were in the placebo group, but was that a result of the vaccine, or was it a fluke? 11 cases might be enough to tell, okay, but we don't know. Will the effectiveness hold up as the trial moves towards completion? We don't know this for sure either. How long will protection last? We don't know this. What do detailed safety data show? We don't know. Does the vaccine reduce the contagiousness of people without symptoms? We don't know that either. And a BBC article adds another one. Does the vaccine stop you from spreading the virus or just from developing symptoms? Again, we don't know, but let's look at this for a minute because it also raises even more concerns. According to the study protocols, participants only received a nasal swab for testing of COVID-19 around the days of the first and second vaccination, not at the 1-month follow-up or any of the other follow-ups after that. So how did the authors of the study know that people got sick within 7 days after the second dose? Well, the protocols require that people self-report. The person has to report any COVID-19 symptoms. And this means that the study participants are not regularly tested for COVID-19, and only those with symptoms end up being reported as COVID-19 cases. The implication of this particular protocol means that if people are not showing symptoms, they're not getting tested, typically. We know that people can have COVID and be asymptomatic, but this protocol means that we don't know if there are asymptomatic carriers. And those asymptomatic carriers, if there are any, could skew the effectiveness of the vaccine downward. Now, some might point to asymptomatic carriers as a positive thing, that it means that vaccinated people could have a less severe case of COVID. In fact, that is in the Moderna press release, that, quote, the primary endpoint is the prevention of symptomatic COVID-19 disease, unquote. Again, there's that word symptomatic. But there are 2 issues with that. First, they could still be contagious and could give other unvaccinated people COVID, which means that everyone has to get the vaccine to be protected. But again, the vaccine won't protect everyone, and not everyone is going to get vaccinated. Thus, it may still promote asymptomatic spread. So if you're vaccinated and Granny isn't, she could still get it from you. Second, you can't really say that the person got a less severe case, an asymptomatic case, because of the vaccine. We just don't know the answer to that question until further study is done. Some might point out that the blood samples for antibody testing that are collected at the follow-ups after the 2 vaccine doses is a good thing, because that also tells you if the person has COVID-19. That's really not accurate. First, it's likely to tell you if the vaccine is sparking the development of antibodies, which may be an indicator that the vaccine may be working. But according to the CDC, the presence of antibodies doesn't mean that the person is currently infected. And the FDA is also clear that these kinds of blood tests shouldn't be used to diagnose COVID-19, because it's not a clear way to tell, because it may only mean that the vaccine making antibodies have done their job. And as a side note, the FDA also says that researchers don't know if the presence of antibodies mean that you are immune to COVID-19 in the future. What both of these vaccines do is take part of the virus's genetic code, messenger RNA, which trains the immune system to block the virus. And it's a new technology that's never been approved for use in any medical product, meaning that we don't know what an mRNA product will do to the body long term. For Pfizer, there are storage and distribution issues. The vaccine has to be stored in a deep freeze, which requires special equipment. One article says that it's minus 103 degrees Fahrenheit, another minus 176 degrees Fahrenheit. This creates distribution problems because we don't have the infrastructure for it right now. Moderna's vaccine doesn't have these problems. You can use standard freezers to ship it. It can be stored in a regular refrigerator for up to 30 days, and it has a room temperature shelf life of about 12 hours. So that means they can take it out and use it and give vaccines for that day. So what is our takeaway here? First of all, a vaccine is coming. That's a really good thing. It's helpful, but there's a lot we don't know. There's a lot of questions that we won't have the answers for some time. We don't know how effective it will be. We don't know how long it will last. We don't know if it will help everyone or just certain populations, and we don't know the long-term safety of the vaccine. The vaccine may also not do what we think it will do, meaning keeping us from getting COVID-19 and stopping the spread. It may only protect us from getting a more severe case, but we don't know that for sure. And we could become asymptomatic carriers, but again, we don't know that for sure. One way and this is really important because we need to understand exactly what a vaccine will and will not do for us. For example, when I was exposed to shingles a long time ago, or lived in a household with someone who had shingles at the time, a doctor told me when I asked about getting a shot that all it does is make sure that you don't have a more severe case. It doesn't necessarily protect you from the virus. Clearly, in the case of Moderna, the vaccine won't necessarily keep us from getting COVID-19, and it won't necessarily stop the spread. According to the press release, it's designed to lessen the severity of the disease and prevent symptomatic COVID. Another endpoint of Moderna's study is to prevent infection. However, because the way their study is designed, they can't know whether it does because they aren't testing for asymptomatic carriers. Neither study is. How does that specifically impact us? My opinion on this right now is that based on what we know about these 2 vaccines so far, and again, there are a lot of unknowns here, but this is what we know so far. It's possible that neither vaccine will protect your clients from getting COVID from you or protect you from getting COVID from your clients. However, with the Moderna vaccine, if you're both vaccinated, it's possible that neither you nor your client will get a severe case. Also, with the Moderna vaccine, if your client is not vaccinated and you are, it could theoretically be possible to spread the virus to them, and vice versa, meaning that if they're vaccinated and you aren't, they could give it to you. And on top of that, whoever is unvaccinated and gets it could actually get anywhere from a mild to a severe case. Again, we just don't know enough yet to determine how all that will shake out. So yes, it's a great thing to have a vaccine. and 2 choices in vaccines. It's really looking hopeful, but we just need to be aware of what the vaccine will and will not do. This update was recorded on November 20th and is an update to the material reported on November 16th. I've also updated the PDF to reflect this information, so use the same download link on the website or in the video notes to get the updated info. Pfizer and BioNTech finished gathering data for their study protocol, which was 2 months after half the people in the study received the second vaccination. According to the study protocol, follow-up data will be collected for 2 years after that second dose. I'm not sure what their application for the emergency authorization to distribute the vaccine will do to that protocol about collecting data, and that's why the question mark on the slide. The data that they've collected so far is the data that they'll submit to the FDA for that emergency authorization. However, we don't know what all that data is yet because Pfizer issued a press release. Again, it's not peer-reviewed information. So here's what they reported in the press release. By the end of the study, 162 people contracted COVID-19. Pfizer said 8 were in the vaccine group for 95% effectiveness. Efficacy in adults over 65 was 94%. They said this without providing any numbers of how many over 65 had contracted COVID and without telling us how many were in the vaccinated group. They also said that, quote, efficacy was consistent across age, gender, race, and ethnicity demographics, unquote, again, without providing specific numbers. And there were 10 severe cases with 1 in the vaccinated group. So at the very least, we know that it is likely to help with severe cases, but not always. While these results are promising, the same questions remain. We don't know how long immunity will last. We don't know if vaccinated people can get the disease and be asymptomatic because they only counted symptomatic people or people who had to get a test because they were a known close contact to someone who was infected. We don't know if vaccinated people can be asymptomatic and contagious. Again, my overall concerns pretty much remain the same as before because they did not do regular follow-up diagnostic testing for COVID-19 after the 2 vaccine doses. And I think it's important to fully understand what it is that we are getting when we do get vaccinated. Also, I want to be clear that I'm not discouraging people from getting the vaccine. Far from it. Partial protection or protection from severe cases is really important. We just need to recognize that we still need to take precautions like wearing masks, physical distancing, and so on to protect the people around us who are not vaccinated. And we also need to consider whether we will get vaccinated or whether we will require that our clients be vaccinated too. Since this is such an important topic, I'll update this video with Moderna's information once we get that information too. So let's go back to the November 16th news brief. On to the next topic. The CDC expanded its definition of close contact. Let's look at it first, then I'll talk about the takeaway for massage therapists. Before, the old definition consisted of at least 15 consecutive minutes of exposure at 6 feet or less. Now it's 15 cumulative minutes of exposure at 6 feet or less within a 24-hour period. And in the notes, I put a reference to a case study about a prison guard illustrating the point of the new guidelines as being cumulative. But they also now tell you at what point during the other person's infection. For example, they say 2 days before the infected person's illness onset. This makes some sense because according to the CDC, the person has the most viral shedding around the onset of symptoms. But other science shows us that a person can be contagious up to 72 hours before showing symptoms. So, but what if the person infected was asymptomatic? Now they say 2 days prior to test specimen collection. This makes a little bit less sense to me because an asymptomatic person could be infectious for several days before they're ever discovered, then tested. But they need some kind of benchmark. So this is it. But this led to an interesting question. Is the length of contagion the same or different for asymptomatic and symptomatic carriers? I found conflicting evidence on this. My own personal opinion is to treat them the same. The study that said they weren't the same was done earlier in the pandemic and tested fewer people. So I would tend to lean toward newer and larger study results. And number 2, I couldn't easily find more than one study showing that it was shorter. I'll admit I didn't try very hard, just a quick Google Scholar search on that. but I did find more than one saying that they were about the same. I put one of them in the notes. If you can find more than one study with the same conclusion, I'd lean toward that, and that's why I'm leaning towards treating them the same. And number three, since we really don't know because we're still finding out more about the virus, I think it's important to err on the side of caution. So we know to consider them a close contact if we spent a cumulative amount of time from 2 days before symptom onset or a test was administered. And that continues until the time the patient is isolated. And this also makes sense because you wouldn't treat the person if they were isolated. The CDC also outlines several factors that are also considered when defining if someone is a close contact. And these are things we already know about, like proximity, duration, ventilation, crowding, indoor or outdoor exposure, along with whether the infected person is singing, coughing, or shouting. But let's jump to the takeaways here, because the rest of the guidance does have a bearing on us that I'll get to in a minute. So for example, the first takeaway is that cumulative times means add up all of your potential exposure time. Some therapists went to 15-minute sessions thinking that that would help. Well, and it doesn't. We now know that it doesn't. Limiting your sessions to 15 minutes is now no longer a viable solution unless you only do one 15-minute session in a 24-hour period. And as we've always known, treat everyone as a potential disease vector. And it informs your questionnaire and agreements with your clients. If a person shows symptoms 2 or 3 days after seeing you, they need to call you. And the same goes for you. If you're showing symptoms, you need to call them. If a person is tested within a few days of seeing you, they need to call you. I'd also suggest longer that they're tested within more than a few days of seeing you. But the guidelines say 2 days. And the same goes for you. If you're tested and you've seen a client, it's important for you to call them as well. There's something in the CDC guidance that I haven't covered so far. First, the guidance clearly says that the determination of close contact should not take into consideration whether they are wearing respiratory PPE, meaning that the person is considered a close contact even if they are wearing an N95, and to some extent for you too, because what's happening with this is the CDC acknowledges that the general public doesn't know how to fit or wear an N95 properly. So they're saying that you can't assume that the person on your table knows how to fit it properly. And if yours isn't fitted properly, you're also considered a close contact. And they also go on to say, at this quote, at this time, differential determination of close contact for those using fabric face coverings is not recommended, unquote. I take that to mean what we've been saying all along, that masks only work if you're physical distancing. So even if they are wearing a cloth mask, you're still a close contact in your sessions particularly. And personally, I would also apply that to other masks like surgical masks just to be on the safe side too. So that's all about masks. On to the next topic, which we've talked about before, coagulation issues. There's new information. Researchers have now found that autoantibodies drive the cycle behind the inflammation that leads to clotting. And along with that, these autoantibodies are the same ones found in those with antiphospholipid syndrome or sticky blood syndrome, or Hughes syndrome is another one. It's a preliminary finding, one that hasn't been replicated yet, but it gives us a little bit better picture of what's going on. But the most alarming statistic around this is that the researchers found that half of the hospitalized patients, half of people who were hospitalized had these antibodies, which means that all of these people are in danger of developing clots. But the good news is that this can lead to better treatments to reduce the risk of clotting. And on a personal note, all of this sounds kind of scary, but I actually have a client, or I had one until a pandemic, had a client with antiphospholipid syndrome, which means that massage therapy treatment is not contraindicated if the primary care provider signs off on the treatment. And that's the important thing here with regards to our information for our takeaway. It reaffirms our concerns regarding clotting, that it's pretty common, and it provides a better picture for treatment. So for example, with a doctor's clearance, you can provide treatment. For example, a patient is usually, or a doctor's patient is usually on medication. So your client is usually being treated for that. And that's the important thing here, is get that doctor's clearance and make sure that the condition is being managed. You want to make sure it's being managed, okay, before you do any kind of treatment. But here are a few more things to keep in mind, is to treat according to those medication contraindications and what we know about those contraindications for different medications. Also, Deep penetrating work is contraindicated. And we also want to take care around those endangerment sites as well. Okay, and that's our information for coagulation. On to the next topic, prevalence of common symptoms. A systematic review confirmed what we already know, but it's important to talk about it because a systematic review looks at a bunch of studies and looks for trends. So it's much better than just a simple study, which makes it worth noting. So look for these in your practice when screening people. And here are the most common symptoms and their prevalence. For example, fever, 81% of clients will have that who are positive for COVID. They will cough, almost 63%. 38%, more than a third, will have fatigue, and anorexia and loss of appetite, almost 34%. So since this was a systematic review, this will be the last time I talk about the subject unless another systematic review comes along and changes everything. But again, these are good things to look for in your practice as possible indicators that a person may have COVID and for you to refer out when they do. So on to the next topic, and that is mask studies. There's more here. They fall into two general categories, but let's look at the first one. Does wearing a mask help stop the spread? Yes, they do. We know this. But I want to talk about a couple of studies that came up during the last month. A study regarding Tennessee infection rates showed that hospitals that serve those without mask requirements see the highest rate of hospitalizations. And the curve flattens in counties where masks are required. Even with the surge in early October, the number of hospitalizations was much higher in those areas not requiring masks. So that was a Vanderbilt study. Another study regarding Kansas infection rates found a 50% reduction in the spread of the disease in counties that had a mask mandate as opposed to those counties that didn't. Both the Tennessee and Kansas studies were careful to point out that wearing a mask doesn't stop the spread, but that they slow it. The other category of mask studies concerns the question, does oxygen saturation decrease when wearing a mask? And no, it doesn't. Last month, we talked about how and why wearing a mask doesn't cause hypoxia or carbon dioxide poisoning. So check out the notes on that if you want. This month, there's more evidence to add what we already know. This time, a group over 65 with a mean age of 76 and a half used a fingertip pulse oximeter to take a bunch of readings before, some readings during, and some readings after wearing a mask. They rested or did their usual activities, and the results showed no difference in oxygen saturation, debunking the claim that wearing a mask causes hypoxia. This will be the last time that I talk about masks unless there's a systematic study or evidence points to something else entirely. And yes, one other topic that happened this month is that the CDC did issue some new guidance on masks and wearing masks and why you should wear them. And I didn't have time to do my deep dive on that, but I will next month. So I'm going to defer that one until the next time we meet. I also had a question that I didn't get to this time because there was just so much to get to this month. And so that's all we're going to talk about today. I really appreciate you taking a look at the video, and thank you for watching.